Good morning, everyone, and welcome to Within's Continuing Education Webinar Provider Series. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to our presenter for today, Ronnie Lee. Ronnie Lee is a licensed psychologist in the state of Texas who recently completed his postdoctoral fellowship at Baylor College of Medicine and received a doctoral degree in clinical psychology from Albizu University. His prior clinical experiences have consisted of Jackson Memorial, University of Miami Hospital, Regional Memorial Neuroscience Institute, and Clementine of Miami. The majority of Ronnie's training has taken place within a medical or residential setting, with a particular emphasis on behavioral medicine, eating disorders, consultation liaison, special immunology, and psychological assessment. Currently, Ronnie is a primary therapist here at Within Health, focusing on the treatment of eating disorders. Before we start, I do have some general information to go over for the CEU and the CME credits. For the CEU credits, evaluations will be sent to the email that you use registering for this presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CE Go dashboard for all things CE related. We will not be providing the slides today. However, a video of the presentation will be recorded and will be available via that CE Go dashboard. You will not get credit for just watching the video. You do need to attend live in order to receive that credit. And again, to access that video or your evaluation, please utilize that CE Go dashboard. For the CME credits, however, please email either myself or our Director of Brand and Development, Jamie Singletary, and that will provide you with the certificate in regards to the CME. I'll provide both of our emails below, as well as the contact information for CE Go in case you need any additional support with your dashboard. If there are any issues accessing anything, again, please feel free to email myself or Jamie. We also welcome any questions throughout the presentation, so please feel free to utilize the chat function or the Q&A function, and we will work on getting those questions answered at the end of the presentation. We were so excited to have Ronnie with us today, and we're so excited to have all of you and sharing in the space. I will now pass things over to Ronnie.
Thank you so much, Ashley, as always, and a shout out to you and Jamie as well. Thank you for inviting me back to give another talk. I'm super excited and I'll accept it anytime. But let's go ahead and get started. So this will be a little bit of a continuation from my talk a few months ago. I don't expect anybody to remember anything that I said, so I'll give a little bit of like preface to what I'm about to say, leading into today's talk, considerations for psychological evaluation in a remote setting, which we are in right now. Before I start, as I always say, just a disclaimer: in no way, shape, or form am I an expert in anything that I am speaking about today. As Ashley mentioned, I do have past training, specifically at Memorial Regional Hospital for 2 years doing training with psych assessments and training at Dallas VA, and a few other places as well. But I'm still always learning, always gaining competence, and especially in this particular context, right? Testing in a remote setting. I also want to disclaim that I have no training as a neuropsychologist. I'm not a neuropsychologist, and anything related to neuropsych, I will always defer out, right? So we'll talk a little bit about like severity and presentation, what is appropriate, what isn't appropriate, right? So just want to give those two up front. On a lighthearted note, I always try to match a quote with the talk that I'm doing, but I could not find one. So I saw this one at like midnight when I was putting this together at some point over the last week, and it made me giggle. So I hope it gives you a little smile as well. But all right, let's hop into the first slide. So before we start here, let me just say, my last talk really kind of dove a little bit into like why there would even be a consideration of testing with eating disorders. We talked a lot about a bunch of different studies that looked at eating disorders, how it can impact our cognitive presentation. The majority of literature was focused on anorexia nervosa, But the conclusion after my literature review is I think like that is kind of an outdated view, right? That anorexia nervosa is the only eating disorder that can cause some cognitive concerns, and the the literature shows that as well, that there's many other diagnoses and considerations, right? Specifically, there's some interesting studies that we talked about considering RFID, considering bulimia nervosa, and a few others, and like a combined presentation as well. And really what it tells us is that um, to better understand our clients and our patients, we need to kind of understand how they're thinking, understand different ways that they are functioning on a day-to-day basis, and understand the severity, right, of what's going on. So a lot of that can just be done by what we're doing now, right? Just talking, right, in clinical interview and listening. But there is this, I think, value in being able to have or have the possibility to evaluate even a little bit further, right? And there's many reasons why this could be an option. And we'll start to talk about that a little bit. But that was really the basis of my last talk, right? It's like, why would this even be something that we do? And so I want to just expand it out from not only just like a cognitive perspective, but just generally, what can a psychological evaluation help us with, and how can we use it to better guide our treatment with our individual clients? Um, so I'll read this specifically from the slide. I'll try not to read a lot from the slide, but I want to get this right. Psychological evaluation refers to the process of evaluating an individual's mental health and behavioral functioning through the use of standardized tests and assessments. And so if that is just like a little bit gray for anybody, one of the examples that I use when I think about giving a talk like this is and anything related to measurement-based care, right? Like that also kind of fits this bill, right? We're constantly evaluating an individual, depending on the questionnaires slash assessments that are provided. They are or should be standardized right across the board. And we're using that to kind of like guide and treatment plan, which leads to the next bullet point, right? We utilize this to determine diagnoses if needed, course of action, and treatment planning throughout their stay in treatment. So I kind of use NBC as like a anchor point here. And then what we'll be talking about a little bit later on is just that, but just on a larger scale, right? And so those assessments, they are created so you can give them every so often, right? Depending on what it is, right? It can be every 2 weeks, every few months. These have a little bit more of a gap, right? So if you do a test like this, typically you have to wait a few years to do the same test, but there's so many tests that you can actually like mix and match and still try to achieve what you're looking for. But types of psychological evaluations, and these are not a conclusive list. These are just like four that I feel like are probably the most abundant. If I'm missing something, you can go ahead and pop it in the chat. But emotional and personality functioning. So this is, I mean, I say psychodiagnostic, but I was reading the literature, and this is the um, terminology used a bit more. So of course, this is where we're trying to identify personality traits, characteristics, kind of understand how emotions, mood in general is impacting this individual on a daily basis. With the psychodiagnostic piece to it, it can also help with diagnosing, or at least confirm, rule out certain diagnoses. Of course, if the tests are valid, if they're not, then it's practically useless. Well, not useless. You can pull some value from it, but really wouldn't be able to diagnose with any invalid tests. Um, Psychoeducational. So these are amazing school counselors, school social workers, school psychologists, and so on, who are doing great work, the educational piece. Not only, and I think when people think about it, it's like specifically like IQ testing or academic testing, but also like career path testing as well is something that is really prominent in high school and in the early college years, kind of like guiding that process. Child and pediatric, I don't have a ton of child testing experience, but I do know that it is extremely useful. So there's a lot of great options there, like the Woodcock-Johnson, the Wyatt. There's so many that can really nail down, if milestones are being met at certain levels. And I mean, it goes very young actually. So I mean, we could test like a 2-year-old, right? And identify like what milestones they may be struggling with. Um, a lot of times a pediatrician will refer, right? Because they may not have the expressive ability to kind of tell what is going on cognitively. So different ways to capture that, I think is really cool. And then lastly, neuropsychological and cognitive are kind of combined together, right? So um, the neuropsych piece, this is your real I would say like heavy batteries, right? Testing for 7, 8 hours, having to split up in multiple days, really trying to capture each part of the brain. I think that's the beauty of neuropsych and why it is probably one of the strongest of our evaluations, because there is so much research that backs it, and it specifically targets certain areas of our brain, right? So we have certain tests that will target like our language center, um, Broca's area, Wernicke's area, things like that. And kind of like work our way around to have this like global picture, right? It can be used with imaging, like fMRI, to help reinforce what they're seeing, right? And working closely with neurologists as well. Um, Also, just another tidbit about neuropsychological testing can be done actually when they're doing a form of open brain surgery. So in the hospital I was in at Regional Memorial under Dr. Natalie Brose, they were doing a ton of awesome work before they would remove certain tumors or go in for other various interventions. Um, they they would keep the patient awake, and as they're pressing on different parts of the brain or stimulating different parts of the brain, um, Dr. Brose would be giving them a very small battery, right? So they're alert. Obviously, they're not feeling any pain up there, but they're alert and they're able to give answers, right? And that can help guide the surgeons and be able to let them know, okay, yes, we want to remove this portion or this tumor. However, if we do that, then semantic fluency is impacted, right? Or like naming is impacted, right? Things like that. Then cognitive, I spent basically the whole last talk talking about it. Just give us an idea of how somebody is working through their day-to-day habits, their day-to-day functioning, and if it's impacting things like memory, things like problem solving, processing speed. Basically, not at a level of neuropsychological impact, but just below that it may impact their ability to operate within our treatment requests at a high level, right? All right, so what are the aims of, but really I'm kind of grouping all of the four and others, right, that we'll talk about. Want to be able to understand which issues are impacting our clients the most, right? And so as I mentioned, number one in this is our clinical interview and how we're interacting with this client, right? This is all supplemental, right? Just gives us a better indication. Or maybe we have a client that just isn't as expressive, right? We're not really sure what's going on. Or there's like a lot of diagnostic complexity, right? I had a client recently who I shared this last time as well. So I guess it wasn't recently, but not a while ago, who was diagnosed with panic disorder like 5 years ago and came in and still had the diagnosis, but they had not had a panic attack in years, right? So it just kind of it reinforces our need as clinicians, right? Like, let's make sure, right? Instead of saying, oh, okay, well, an individual comes in with this diagnosis, therefore we'll just like give it by history, right? It must be still there, right? It's up to us as clinicians to be able to clarify which diagnoses are current, which diagnoses are not. Strengths and weaknesses. This is really useful in terms of treatment planning and support, identifying where we can help support the patient a bit more, right? And maybe, I've heard this before, like, I don't know what type of support I need. I don't know how something is impacting me. So doing a brief evaluation can help assist in that. Diagnoses as well. I just listed a few here, but virtually the majority of DSM diagnoses, you need some form of assessment, right? Or at least matching criteria. I do want to take a moment, and I know that this comes with an asterisk, right? Because it's not uncommon for clinicians to shy away from diagnosing, right? Or to feel like a diagnosis is a label. I am privy to that. I do understand. I'm not here to argue either side, but what I will say is that I think with psychological evaluation, excuse me, that a diagnosis does not need to be given, right? We can use the evaluation to just kind of understand the patient a bit better, more so than just like, placing a diagnosis or label on them, right? So I know some maybe like really unwilling, right, to give like a certain personality diagnosis, which is perfectly fine, but it could help us look a little bit more like certain traits and characteristics. Okay. Talked about the cognitive aims as well. And of course, the MBC kind of comes into play at the last bullet point, right? Monitoring individual progress throughout treatment and making any necessary adjustments. So is there a need for remote evaluation? Yes, next slide. No, I'm joking. Yeah, of course. I believe that there's a need, and I think that the research and literature shows that as well. I think that in general, there's a need for telehealth and telemedicine, and following COVID, it kind of sparked it a bit more. But COVID was not the starting point of the research and kind of question about remote evaluation being an option. There's studies that date back to 2000 that kind of take into consideration like telephone assessment in different ways, that assessment can be conducted without being face to face. Of course, that's 2 decades ago, which is insane to think that 2000, the year 2000, 2 decades ago. But at that time, right, because of the technological barriers, I'll say, it's really hard to kind of understand, or excuse me, it was really difficult to find ways to test subjects and make it valid, right, and make it easy to replicate, right? But as the years progressed and things got better technologically, or maybe not, in other aspects of tech, but we were able to kind of understand how we can use this to reach maybe patients who aren't able to come into the office, or rural folks as well, in different ways to get creative with some of these assessments to provide them the care and the standard of care that everybody should have and can have. But of course, following COVID, there was this boom of remote testing. I mean, well, generally just telehealth and telemedicine, but also remote testing research. I could have done a whole literature review here, but I opted not to for everybody's sake. But ton of studies aimed at effectiveness, which measurements are actually valid, which are reliable, which can be like tweaked in different ways that wouldn't impact test security or test standards. But there's one specific research study I put here by Parks and colleagues that looked at it was like a randomized control, and being able to provide the direction, that specific battery to each person. And what they saw is that there wasn't a significant difference in terms of ability to understand, ability to interact. And they tried to match the clients up as best as they could to demographics and intelligence levels and things like that. And there were no significant differences. All right, so ethics and legal. I think this is, I think sometimes, and this is just my opinion, but I think sometimes, like, as the field advances quickly for whatever reason, um, we have to adapt to it, and then the ethics and legal ramifications come into play. And one of the examples of that is, following COVID, there was the big spike of like e-passports, right? Where psychologists can practice in multiple states. And I remember when I was going through that process, I wasn't asked about like the ethic, and this is not a shot at the APA. So if you're listening, APA, it's not a shot at you. But there was no review of like ethical and like legal ramifications of or at least an update, right, of like working across state lines using the e-passport. Um, but now I believe from I was talking to a colleague of mine, they are requiring just kind of like a brief review of the ethics and like legal ramifications of that, what to do when certain situations arise, what state laws take into effect, and things that kind of like come after the fact, right? COVID happened. It was a very difficult time, and people were trying to adjust. So it was more so about trying to get care to many individuals, right? And then we have the ethics and legal. I think same thing with testing, right? With remote evaluation. Um, two of the and these are the two that I picked out specifically. I was doing some research on Stoller Carter Hammers in Cullum. They done some great work in this area, and they're doing amazing work, and I have them cited a few times. Um, they conducted one of the first true neuropsychological batteries, to see if it was able to be done over remote testing. But they posit kind of the idea of like why this is a need, right? Why we should be aware of it from an ethical and legal standpoint. Number one, with principle A, right? Psychologists strive to benefit those with whom they work and take care to do no harm, right? And that intersects with principle D of justice, which psychologists recognize that fairness and justice entitle all persons to access to and benefit from contributions of psychology. So at that intersection, we have kind of this, if we have the ability and it will not bring harm, it is our duty in many ways to provide it as a service. Continue on with the legal aspects of things. The laws and regulations, it holds more weight where the patient is actually located at state. So if you are um, a e-passport practicing psychologist, or if you have just multiple licensures, right, at any level, the state that the patient is in takes precedence, right? And again, that's something that is really important. I was going to kind of fly through these slides, but not only for myself, right, but just generally for the company that anybody works for. If you're doing this work for them in private practice, it kind of falls on you. But if you're doing it for a company, it affects more than just the clinician, right? So understanding what that looks like and getting familiar, maybe not with the whole handbook, right, of bylaws in that state, but at least understanding what to do when certain situations arise, right? I think the last thing anybody would want is you're doing a clinical interview with somebody, doing remote testing, and they say something like, "Oh, like I have this plan to like really hurt my boss, or like uh, do something to my neighbor." But luckily this is confidential, so you won't say anything to anybody, right? And at that time, it would really behoove the individual who's testing to understand what is and what isn't allowed for each state. Duty to warn, duty to report. If you're in Florida, I'm sure you're aware of Baker Act, right? But that's different in Texas, and we have different reasons to utilize holds, and our hold length is different. So kind of small details like that is really important. And of course, record keeping, how long you have to keep records for. So the APA is about 7 years, right? But each state will have different record keeping year requirements that will uphold. and of course, patient confidentiality, which is across the board. All right, and just some Pearson test publisher guidelines as the and Pearson is probably one of the leading, I would say, leading the race in terms of being able to standardize some of the remote testing and come up with different ways to do it, come up and make norms available for it as well. I'm not going to read through all of these, but basically it just says, because we are administering tests in a remote setting, just to be aware, right, of number one, we're qualified to do so. Number two, which or whatever assessments that you are sending over, if you need to, that it won't be replicated, right? That there won't be like screenshots taken, just like all of the kind of like I would say like issues that could arise, right, from providing materials to individuals. Because depending on the battery, you will have to send over, you may have to send over like response sheets ahead of time so that they have it. So when you're presenting it, they already have it down, right? So then they have to then scan it back to you. And then there's specific processes where, basically you're watching them kind of discard the copy to make sure that it's not something that can be duplicated again, right? This is all for test security, of course. Okay. And other issues to consider, and a lot of this I kind of gathered from Stolwick and colleagues. When we're doing this type of evaluation or assessment, we want to be wary of a few different factors that could be unique, right, to this space. So cognitive severity or developmental level. I'll start with developmental level, right? There's many, I think, not many, but at least a few assessments that I've seen that it takes probably a little bit average to higher level of like tech understanding, like different ways to manipulate the screen and things like that. So we want to be mindful of where the client is at that, right? And if it will impact just general ability to work through the test, right? Using our own barometer, if you will, right? Of, is this something that could impact outcomes? Same thing with like severity of like understanding instructions of certain tests and understanding like different directions of, for instance, the MMPI. It's not complicated, but it's a little bit different, right? Where you're sending a link to this individual, so they have to be able to get into their email, open the link, fill out all the information, submit it back. And so these steps we also want to take into consideration, right? Is there cognitive severity impacting that? Therapeutic needs, feedback, and lack of rapport. I thought this was a really interesting point by Stolwick and colleagues. And I think it's challenging to quantify, right? Like how much this does impact. But what I took from it basically is, depending on the type of assessment you're doing, you could be providing feedback for something that could be uncomfortable, right? Off the top of my head, I don't know, like something like histrionic personality disorder, right? Like let's say that is flagged or that is a rule out. Even though the individual is likely the one seeking services, we have to be mindful of, is giving this feedback over a remote medium, is it appropriate, right? Do we have the time, the resources to invest and kind of allow them to understand? And it's not, I don't think it's drastically different from what would occur in person face to face. However, in person face to face, you kind of, you have a different feel of what's going on and how the conversation is going at times. And you have the ability to maybe stay longer, right? Or, have them be, I don't know, talk to another clinician in the practice as well. But remote, depending on time, depending on if you need to move to another patient, maybe that isn't feasible, right? So kind of understanding those barriers as well. That was a little bit, I think I worded that oddly, so I hope you understand what I was getting at. Psychiatric or behavioral stability, this goes without saying, right? I mean, basically mental status exam, right? Is this individual, currently in a manic episode or unable to understand the purpose of what we're doing and why we're doing it? Then other factors to consider, stable internet connection, right? That is not a given, even in 2024. So just being mindful, right, of where everybody's internet connection is, and how to circumvent issues. I know that Pearson, they will also, depending on the test, they will also mail the person their own iPad, which I thought was really cool. As a way to kind of circumvent internet connections. Consistent fast audiovisual connection, which goes in with the first bullet point. Cultural barriers, language barriers as well, tech competence in general, and then general comorbidities. Right. So I actually showed this in my last talk. This was taken from Salvadori and Pantoni, 2023. And it just kind of gives like a very, very, very like brief and superficial breakdown of like when would it be feasible, right, to use like teleneuropsych. So this study was actually looking at teleneuropsychology, but like general cognitive evaluation is really what it's under, right? Is there a need for it? Is there like or can we do second level cognitive evaluations? And I'll get to what that means in a moment. But is it available? Like, can we answer the referral question by using specific tests? And if we can, right, then yes, it kind of goes back to principle A and principle D, right? If we are trying to accommodate our patients the best that we can, and do no harm, right? If we have the option to do this, it is kind of within our rights that we should do it. Or excuse me, the client's rights. When to consider, I won't stay here too long, but generally if there's cognitive changes, self-care status changes, physical symptoms, psychiatric symptoms, and specific diagnostic concerns. Under physical symptoms, these are all pretty like neurological in nature. I mean, really, if those occur at a high level and we're worried about their cognitive status, that would be a reason to refer out. But at least, possibly doing something like a MoCA or MMSE, which you can do that virtually, would be something to consider. All right, the assessment process, pretty straightforward. Pre-assessment, we want to pre-brief with the patient, kind of understand the purpose of the referral, who referred, why, what they're seeking. If we're doing it in-house, right, for, let's say within health, it would be a little bit more streamlined, right, because typically the referring clinician would be able to kind of pre-brief all of this with the patient before they get tested. Documenting verbal consent, as well, and discuss testing options and purpose and the assessment, of course, including the clinical interview, formal testing, and then post-assessment with debrief, reviewing the full report with the patient and anybody else who we have ROI on file with, that they would like to be there, provide specific feedback and diagnoses if applicable. And I say if applicable because many times, especially if we're doing just a general psychological evaluation, I would go as far as saying like it's really rare just to give a diagnosis from this. Like there has to be many components to it. I'm not sure if Dr. Kaylin Elsenbeck is on the call. I was giving like a brief, like 5-minute talk during clinical collaboration, and Dr. Elsenbeck made a really great point just about ADHD testing, right? Is that the psychological evaluation itself, right, that does not determine if somebody has something like ADHD, right? So it's kind of like this global approach. It can help support it, or it can help rule out other things. right? So making sure that if we are giving a diagnosis, we are pretty certain on it, right? And there's more than just like one medium going into it. All right, and here we were chatting a little bit earlier about like second level cognitive tests, if they're available. This is what I'm referring to. So this is from the National Institute for Neurological Disorders and Stroke. And when they say second level tests, they mean basically things that can be given verbally, right? And so there isn't anything that the client actually needs to do or manipulate anything, which the last bullet point down to the right, tests like block design from the waist, trail making, Tower of London, are just not real possibilities at this point because they would need the items to then manipulate. I mean, maybe if AI and Neuralink takes a jump, that could be a possibility, but I think that we're a few decades away from that. So of course, global cognitive efficiency tests like the MOOC and the MMSE, which I think the majority of people have heard of before. These are really easy to give, and they've been adapted to the remote setting as well. Other reasonable options: subtests of the WAIS, semantic fluency, and letter fluency as well. All can be easily administered remotely, and these are just very small percentage of tests. There's so much more. All right. Do I want to? Yeah, we'll go over the R bands. I went over this a little bit last time, so I'm just going to breeze through it. The R bands is the repeatable battery for the assessment of neuropsychological status. Consists of 12 subtests that breaks into 5 scoring cognitive categories. Created for adults, much older adults, but has been adapted over the years and only takes about 20 minutes to administer. Those are the scoring domains on the right. And one of the cool things about the R bands, why I'm highlighting it here, is not only because it leads into the case that I'll be presenting in a little bit, but there's been a lot of research on it, and the Inter-Organizational Practice Committee actually released kind of its own guidelines for how to do this test remotely, because it is so standardized, because there's so many different versions of the R bands. There's like I believe 4 versions of it that can be given. And so these are all kind of like coded into input. Input is what the clinician would be doing, and then the output is how the patient will be responding. And so for instance, the BSD is brief spoken direction. So things like list learning, list recall, digit span, which I did in my case study that I'll be presenting. You have spoken stimuli, and then it's timed as well. So all things that I don't need anybody to manipulate anything. I don't need to send them anything ahead of time. Just things that can be done in a controlled environment. And these are specific telepractice considerations, again, from the IOPC. Considerations when you're doing each subtest, right? So if you're giving the full R bands, it kind of breaks it down for you, specifically what you need, why you need it, from both sides, both the clinician and the examinee. And then really briefly, I just want to talk about the MMPI-3 a little bit because I have some data that I'll be showing. The MMPI, just in general, a standardized personality test just to identify traits, characteristics, and assist with diagnostic clarification. As I mentioned earlier, it is not for diagnosing only, right? If MMPI-3 is given, it's really to help kind of assist and give a better understanding. The diagnosing should be coming from the treating clinician and or physician, but this is supplemental information, right? Provides a bit more. The newest version just came out, MMPI-3, and it was much needed. The MMPI-2 has been out, I believe, since the early 90s. If I'm wrong, please somebody fact check me in the comments. But but I believe since the early 90s, the MMPI-2 came out, and then they came out with the MMPI-2RF, which was like a more condensed version of it. But the MMPI-3 canceled out some of the scales that were outdated, also gave us a bunch of newer norms, right? And I think that was the major issue with the MMPI-2, is that the norms were just really outdated. I mean, America has changed so much from when those norms were created. Um, and now that I'm thinking about it, maybe the norms were from the early 1990s, but the MMPI-2. I don't remember. But in any case, it needed to be revised, and it was. They also added on eating concerns, compulsivity, impulsivity, and self-importance. And there are 52 scales. So the MMPI-3 is about 335 questions that are broken down into 52 scales, which is amazing. It only takes about 20 to 40 minutes. And as I mentioned, Pearson has something called a Q Global software, where they have various tests on there, and almost all of the personality inventories. You can send an email to that person. As I mentioned earlier, they go through it, only takes about 30 minutes. When they submit it, we immediately get an email back saying that it was submitted. Would you like to score it? And it scores in something like 30 seconds, which is amazing because it was only 4 years ago when I was hand scoring the MMPI-2RF, which took much longer than 4 minutes. So awesome stuff by Pearson. But okay, I have a little bit of time to go over just a brief case study. I don't know why I added the exclamation point. Maybe I was excited to give it at first, but I won't go too in depth with this case study. Obviously, everything is de-identified, but I just want to kind of give a brief glimpse of what a small battery using remote evaluations and assessments can look like. So demographics, we have an 18-year-old female presenting with bulimia nervosa, generalized anxiety disorder, and major depressive disorder, referred by parents actually for testing, specifically for possible ADHD-like symptoms. And there was a big concern about bipolar 2, right? So I think a therapists in the past had said, oh, this, looks like bipolar 2 a little bit because of their activation and just their some of the behavioral concerns at the time, right? And I think that this is actually a really good case study because if we kind of look at the literature, right, when we think about ADHD-like symptoms in females, especially females in this age, they're undoubtedly right diagnosed with more mood disorders, right? So it's just kind of like automatically assume that it may be mood related than something else. This client had no significant medical concerns. There was no TBIs or traumatic brain injuries and no loss of consciousness. Obtained verbal and written informed consent. Met with the client a total of 4 times, one for the clinical interview to just kind of review, or excuse me, one for the pre-assessment and clinical interview. It was kind of wrapped in one, and then 2 times for the actual testing. So it was about 2.5 hours. And then the last one was just to go over the assessment with client and with parents there as well. And the method of evaluation, basically the battery, the clinical interview, as I mentioned a few times already, the ASARS, which is a adult ADHD measure. Love to use that one again. And I feel like I have to keep saying this just to clarify, the ASARS by itself, it can give us good indication about ADHD symptoms, but definitely don't want to use it just to diagnose. The Vanderbilt, I gave that to the parents because the parents are so heavily involved, and client was right on the edge, right at 17, 18, and the majority of their complaints were kind of like school related, from the ages of like 15 to 17. And I didn't include this data just because, for time, but the ASARS and the Vanderbilt were both significant. Also gave the MMPI-3, as I just reviewed. the BDI-2 BAI just for general functioning, and then we did subtests of the R bands version A, and then subtests of the WAIS-4. And I think so I mentioned the MMPI-3 is coming or has already came out with the updated version. The new WAIS will be coming out in a few months, but hasn't already. All right. I'm kind of repeating myself here, but a clinical interview provides probably the most significant value when we are talking about these evaluations, right? And um, parent interview if needed as well. That provides a ton of information, and especially just depending on the referral purpose, right? So for this client, reporting academic struggles and almost I'm not going to go over the whole case, but they were almost like held back in a certain grade, a lot of behavioral problems growing up, um, different concerns. And I think like this is kind of like where the like mood possibilities started to come up, because they were so defiant in many ways from the parents' words. No concerns with mental status exam or behavioral observations. Motivation was high for the testing, test validity. Um, so we can give things like the TOM, the test of memory and malingering, to rule out if somebody is, and that's mainly for if there's like specific reward for scoring poor on tests, right? So this is seen a lot in kind of like insurance testing or um, uh, testing for um, specific diagnoses that could provide accommodations, things like that, right? We really want to be hyper vigilant on validity and motivation, like what the purpose is of this test. But no concerns with her. Of course, stable internet connection throughout, received the materials previously and protected email and also protected PDF. All right, so this I just it looks a bit weird because I just pasted it from my report, but it's broken down into 4 categories: immediate memory, language, attention, and delayed memory. And attention and working memory are kind of combined together. If there's any neuropsych people in here or anybody just very well read and cognition, um, you're probably cringing looking at that is together. But I grouped it in just specifically to try to combine and make this as easy to read as possible. So on the left are the subtests, like what exactly we did, the scaled score in the middle, at 8 to 12, average, anything above that, high average, and it keeps going, 6, 7, low average, anything below low average, things like borderline, and then significant impairment below that, really. For this client, list learning was average, but story memory from the R bands was borderline, which is something that is really surprising, especially for their age. And also because we weren't really testing limits with story memory. So what does that tell us? What it tells me just from my experience is just that when items are given to this individual client, when it's pretty structured out, something like list learning where you're just reading words, their auditory memory, auditory immediate memory is not impacted. But when there's a story, so there's multiple elements, and if you've done the R bands before, you know that there's so many elements in that story. That's where we start to have some complications, right? Where we're receiving a lot of information in, trying to encode it, and not even really retrieving it, but just encoding it, it can be difficult. That gives us a little bit of hint of like possible attention as well. Language, perfectly fine. We wouldn't necessarily expect this to be impacted with the ADHD criteria or symptoms. I mean, it could be if we looked even deeper. But with semantic fluency and picture naming, I felt that it was representative, very superior and average. Digit span. This is kind of the other piece of ADHD is working memory is impacted. We didn't do the continuous performance test, which is like the gold standard of ADHD testing in many ways. Um, but we tried to capture that with digit span. The R-band's digit span didn't really push the boundary. She did very well there, but in the waist digit span, if anybody has given it, there's a forward, there's backwards, and then there's like stacking, right? Where you have to kind of like order them. And that can be really challenging. So compared to same age peers, she was in the low average group. And then delayed memory was actually pretty good across the board, which can kind of tell us that maybe there's difficulties with like gathering information and then encoding it for immediate um, response with both immediate memory and working memory, but not so much with delayed memory. So maybe when it is encoded, she's able to retrieve it and have it there, right? Which again leads to like why things like attention can be impacted more so than delayed memory. And this is the MMPI-3. I was going to go through all of this, but I'm quickly running out of time. It is not an invalid protocol. Overreporting was a little bit high, but she was also in quite a bit of distress as well. So we can understand like why the FP is a little high, which is infrequent psychopathology. There was no underreporting, and none of the other validity scales were impacted. The MMPI-3 breaks it down into kind of like these five sections, which actually I really like. I'm not going to go through each one, but basically anything above 60, we want to take a look at. 65 is significant, and then anything above 75 is like clinically significant, right? So, of course, if we look under somatic cognitive dysfunction, fourth over is EAT, which is the eating concerns, 85. Go figure, right? Diagnosed with eating disorder and is here for that specific care. Suicidality was also actually quite high, which maps because of past attempts and just general distress. Anxiety related is high, which maps with the GAD as well. Behavior restricting fears was high. We can also kind of combine that with the eating concerns and eating disorder diagnoses. But we get into thought dysfunction and behavioral dysfunction. And that's when, for me, we can kind of rule out a little bit of the bipolar 2. Really with the behavioral dysfunction, the impulsivity and activation, the way that it maps on the MMPI-3, it really does align a little bit more with an ADHD diagnosis. And also, I mean, just combining that with the clinical interview, it really feels like a bipolar 2 would be way over-diagnosing, at least at this stage. And sure, could come about later in life, but as of right now, we're not seeing any significant episodes of hypomania, any significant episodes of severe depression as well. So I didn't really change anything for diagnoses. Surprise. I've been talking about being careful with diagnosing throughout this time. Most everything was by history. Client came in with a rule out of PTSD. The MMPI-3 actually spit out a few things kind of related to PTSD, but nothing I felt comfortable giving a concrete diagnosis for. Plus, when I talked to them, there was not a ton of significance placed on these symptoms. So the ADHD diagnosis, I had actually multiple conversations with the outpatient psychiatrist. I gave a provisional. I felt that it mapped on from what they were saying from the questionnaires, and also a little bit of what the MMPI-3 provided. Not so much the cognitive piece, although it did kind of track what I was looking at in terms of working memory and immediate memory. But yeah, I gave a provisional. It was not a concrete diagnosis. I allowed the outpatient psychiatrist to utilize their practicing judgment. No general medical concerns, no other conditions to be focused on, and then provided recommendations and feedback. And so specifically for recommendations, they're just kind of things that I think could help with ADHD treatment planning, things like, reminders and working through activation and specific skills, all related to ADHD. Again, I don't touch medication or anything like that, I allow psychiatry to use their judgment in that area. Okay. And that is all I have.
Thank you so much, Ronnie, for sharing and for being present in this space today. We did have one question come through, and it was, are there any gaps in testing that you have found and you would like to see improvements on?
General test, I wonder if like general or remote. I think general testing, I'll say like it's really it's difficult to track the norms, I think, appropriately. It's so, I mean, that's the best I think that we can do right now is just like utilize norms, right? So same age peers with kind of like similar presentation to help. But I mean, one thing that we know about humans is that we are so unique, right? So I think sometimes we place too much of an emphasis on these norms, and it being like, okay, well, compared to these norms, this individual is significant here, but that doesn't necessarily mean, right, that it's significant enough for a diagnosis, right, or significant enough for um, like a change of X, Y, Z. So that's what I would say, just generally with testing, and then with remote testing there's a lot of gaps, right? Number one, you just don't have the wide variety of tests that you would otherwise use. I mentioned earlier the CPT, which is the continuous performance test, which is, in my eyes, like the gold standard of ADHD testing. And you have to be kind of like present with the clinician, and there's different stimuli that pop up on the screen and that you're actively doing in real time. I was searching for like a way to do that. There seems to be a way to do it, but it's not well researched. It's not something that I would feel comfortable doing, and it's also very expensive to do as well. So that's what I would say generally.
Thank you. We actually had one more additional question just to wrap things up. In what ways have you included parents in the testing, specifically a resistant parent?
Yeah, so I can't give a specific. Well, I guess I'll say this. So, like this client that I gave the case study in, parents were highly involved in the case, right? So they were really wanting to understand, if this was like a presentation of bipolar 2. If not, then what else could be going on? And the client was also really involved as well. So it wasn't a situation where parents were just referring and client was like, okay, I guess if I have to do this. Client was very amenable. Also, described the distress like through middle school and high school and feeling like always like overworked cognitively and feeling fatigued. So that's a situation where we take, especially if the relationship is really strong, there's a lot of trust there with the client, really utilizing the parents as their obviously like knowledge, and I mean they know their child way better than I ever could, right? So that clinical interview, not only with the client but also bringing the parents in and kind of understanding what they've been seeing, what tracks, what doesn't track, and also utilizing it just to kind of like confirm things that the client is saying, right? In this case, I don't think there was any malintent or malmotivation, but just confirming like, oh, was it true that in fifth grade, client was almost held back, right, because of behavioral issues that impacted their academic performance, right? Or is it true that they requested like additional time in high school to take certain tests, and just try to map that?
Wonderful. Thank you, Ronnie. And I want you to check out the chat because you're getting some really great love in there. And again, I want to thank you all for being present today and for Ronnie for providing such incredible information and for sharing in this space with us. I also provided my email and Jamie's email again in the chat for those CME credits or any issues with the CEU. Again, a recording will be available within 24 hours, and that'll be on that CE Go dashboard that you use to register for the event. I also want to share our next provider series, which would be the cross section between substance use disorders and eating disorders. That will take place on Friday, August 16th at 2 p.m. Eastern. provided by one of our own senior therapists, Cheryl D'Amato. Registration for that will be available on the website. And I also want to share that our summit will be coming up this October on October 8th through the 11th. Registration for that is also available on our website, so be sure to check those out. And again, I want to thank you all for sharing in this space with us today and for Ronnie for providing such an insightful presentation. Have a great rest of your day, everyone.
Thank you. Thank you, Ashley.